The key components of surge capacity have been coined the 4 S's: staff, stuff, structure, and systems. Shortcomings in any one of these areas will be gaps in your capacity to respond to a surge of patients. Staff, an open bed without a nurse or a ventilator without a respiratory therapist doesn't do much good. Stuff, let's reverse that. You have all the respiratory therapists in the world, but without pediatric-sized endotracheal tubes. It's not really very helpful. Structure, a mass influx of providers that heard about the incident on the news, but no physical space to see patients in, that actually does more harm than good. And systems, surge response requires creative solutions, and without buy-in or pre-planning, your system won't be able to work cohesively. ED decompression is a technique that focuses on 2 of the S's, structure and system. It's the act of freeing up space for potential patients during a surge by moving current patients out of the ER. This requires embracing non-traditional options. To perform decompression as seamless as possible, a significant amount of planning, training, and partner engagement must take place within your system prior to the incident. While sometimes it does feel like the emergency department works in a vacuum, we can't move patients vertically to the floors or to the operating rooms if we don't have plans in place. Decompression requires quick dispose for patients where it's safe to do so. This may mean modifying where patients receive care by setting up non-traditional areas for patient care or cohorting similar patients in areas together. As an example, at the onset of COVID, an additional 2,000 medical and surgical beds were identified in Minnesota simply by institution applying for waivers in order to use non-traditional areas for patient care. It may also mean that inpatient services accept patients from the emergency department prior to their workup being completed if it isn't going to change their disposition. It means that planned or elective admissions or surgeries are paused until the system knows whether there's going to be OR or bed space available. In this scenario, you're an inpatient provider. How can you help the emergency department? You have to anticipate that at least some of that surge in the EC is going to result in admissions to your service. You can help by looking at your service and applying what's called reverse triage. This is when you identify inpatients that are at low risk for untoward events and discharge them back to their homes, rapidly increasing inpatient capacity. This is applied in order to give individuals that have been affected by the disaster equal consideration for inpatient resources. One of the resources that your hospital may use is called triage by resource allocation for inpatient, or TRAIN for short. This was created by Lucille Packard Children's Hospital in Palo Alto, California. It was initially intended to quickly assess transportation needs in the event that a mass evacuation is needed. But something that it can also reveal is which patients have been assigned blue in this matrix. This means that they're not requiring any equipment for life support, they don't require any monitoring, they're taking all of their medications and meals by mouth, and they're safe for transport in a private vehicle. This might be where you could start when you're needing to identify those patients that could be discharged home to balance your inpatient resources.